Welcome back to the Iron Sights podcast. I'm here with Dr. Rebeca Ivory. She's a good buddy of mine that I met probably, I don't know, was it about a year and a half ago we got introduced? Mm-hmm. Something like that, through our good friends out at the Performance First facility in Virginia Beach, that being Jeff Nichols and his amazing wife out there, who invited me out to and Cece, we came out for they held a seminar for basically, I would say this, for professionals to get in front of people that might be candidates to go into some type of special operations selection. And man, there were a bunch of veterans there of that process, or a bunch of young men there who were exploring and I would say taking care of their opportunities. And then I had the opportunity to listen to you present. And we had some conversations beforehand coming into this, but I was so impressed. And I'm like, at some point, I have to get to where you are in the world. And we have to sit down and do this in person. The moon, sun, and stars just haven't worked out. So I'm like, this is ridiculous. We got to get together. So welcome to the show, Rebeca. It's so good to have you.
Thank you. Thank you for the invitation. Thank you for having me. I am so excited to be here.
So I'm going to let you get into it because there's no way I could properly introduce the things that who you are, like your credentials, what you're doing on a daily, weekly, monthly basis. So I'm going to let you do that. I know there's some things you got to kind of put out here in front based on your qualifications of what you do for work. So I'm going to let you do that right away, and then we can kind of jump into it.
Perfect.
Shoot.
All right. Hi, everyone. I'm Rebeca Ivory. I'm a doctor of nursing practice, so I'm a nurse with a doctorate. I'm a psychiatric and mental health nurse practitioner. I own a business called Tactical Psychiatry. That is who I'm representing today. That's my private practice. I also am a federal employee, and I am only representing myself today. I do not represent any other employer of mine. I'm only representing my own beliefs and work here. So I own Tactical Psychiatry. I provide one-on-one group mental health support specifically for special operators. I work with military, federal agency special operators, past and present, primarily tier 1, as well as some of the agency operators.
When you say agencies, who do you mean?
The 3-letter agencies.
Can you say it? Oh, got you.
Alphabet soup. I also am a TBI researcher. I'm basically a professional nerd. I honestly think that is the best way to explain what it is that I do. And I'm a professional nerd. I'm a professional scientist. And my area of research is special operators' brains. What makes them tick, what makes them different, injuries to their brains and nervous systems, and how it affects their mental health and their outcomes, and how the heck do we treat what is going on with them, with their injuries, in a way that is culturally acceptable to them, because the special operations community is such they have their own culture, interests and requirements. If they're still operating, they might not be able to actually take part in traditional mental health treatment, and they actually may not want to, and that is okay. So how do we actually still care for them? That's really my area of expertise.
Man, there's so much there. I mean, that like I said, there was no way I was going to attempt to go there, and there are so many things in between that we've talked about offline that are going to come up along the way in this conversation. I think the first question that probably most people are asking is, how did this lady wind up in this space? Like, what is the origin story of this? Can you talk about that?
Absolutely. So when I decided to go back for my doctorate, typically, you have to do a dissertation, and usually doctoral students will choose something that, pushes science forward, but isn't really meaningful, or it's meaningful just in a very small way. Because you're supposed to be learning the process. And that is not who I am. I'm someone who just kind of, jumps in, straight into the fire, all in. So I really wanted to be helpful to the military. So I happened to have a lot of friends at that point who were military healthcare professionals. And so it was easy to just kind of network with them, and they networked me with other people. And I kept asking, what would actually be helpful? What would actually be helpful? And I finally got to this guy who would definitely know what he's talking about. And he must have had a really bad day with Navy SEALs. And he got me on the phone and he's like, you have 3 minutes. I heard that you are a nurse and you're getting your doctorate and you want to help the Navy. So if you want to help us, you're going to talk to Navy SEALs about their mental health. And I said, and then he's like, if that's what you want to, if you want to help us, that's what you're going to do. And like hung up the phone. And,
wow, this is weird.
I know,
wait,
right?
I feel like you left something out here.
No,
what was the genesis of this? No?
I had like networked to this guy who I don't want to say who it was, but he was somebody who would definitely know needs of the Navy in terms of psychological health and mental health and health generally. And someone had asked him to please speak with me. And that's sort of how it happened. And I got off the phone with him and thought to myself, well, I don't really know any SEALs, but I don't know. Maybe I should do this. So I just started contacting some SEALs. This was years ago. This was 7 years ago, 7.5 years ago. So there were famous SEALs, but it wasn't special operations in social media wasn't quite the way it is now. Right, so if I wanted to contact somebody who was like a verified and known SEAL who was out, who was on social media, maybe they had a business, they had whatever it might be, they actually answered me. And I just asked guys for 5 minutes of their time. I explained to them that, I really wanted to work with their community and I'm a nurse and I'm getting my doctorate. And I wanted to know what they thought their community needed in terms of health.
I wonder how this was received initially.
No problem. Guys were very happy to talk to me. Mm-hmm.
Really?
Yep.
And was it more of like, were they shocked? Were they surprised that somebody was actually reaching out to them? Or was this like, hey, we've been getting pretty good, taken care of pretty well. And we know that we need this help, or I know that I need this help. And so thanks for reaching out. Or was it like, oh my God, like nobody's ever talked to me about this before. I know I need to be talking to somebody about this. Thank you so much. Well, or was it in between? What can you tell me?
It was, I asked for 5 minutes. I told them ahead of time what questions I was going to ask. And I don't think I had a single call that lasted less than an hour because typically, I'm sort of an anonymous voice on the other end of the phone. I'm a nurse. Yeah. And, kind voice. And I've been working in psych for a while as a nurse at that point. And they wanted to talk to me about things. And so typically they found me as somebody that they could tell some of the worst things that ever happened to them, just about me right on the phone. It was frequent when they would say, I've never even told my wife this. And what happened is the first guy or two that I talked to, we were on the phone for like over an hour and they started passing me off to their friends. So now guys are saying, hey, there's this woman, Rebecca, who's a nurse, who's going to be a doctoral student. Anything you tell her, she can't tell anyone. She's just, this wasn't research. This was just, I'm trying to get background information on what's going on in the community, but I'm not going to tell anyone what you told me. And I wasn't even collecting their names and numbers unless they said it was okay, just so I could follow up with them. And I just started getting telephone calls at all hours of the day and night from SEALs.
So a little bit of this is the veil of anonymity and this, I guess, safety mechanism that's there, and that you're not part of this other machine, that you're just doing research. Probably get that. I wonder, so I'm going to flip the script on you. Ask sort of how they were receiving this. How are you taking in all this information? That's because first off, it's brand new, right, in a lot of ways. Secondly, nobody's really doing this at this point yet. Now, maybe there's some research going on out there, but nobody knows about any of it, right? So you're walking into this stuff and you're just getting hammered, and I mean that in a professional way, with all of this new stuff that, again, if they haven't told their wives about it, or they're not talking about it with their buddies, like it's going to be some of this is going to be pretty heavy, and it's going to go way beyond whatever happened on a deployment, I'm sure.
Yes.
So how are you taking all this in?
I mean, luckily I had worked in psych nursing for long enough that I had a foundation for figuring out how I'm going to process this. But ultimately I spoke with a whole bunch of other people who work in psych. They gave me some pointers and they suggested that I find a very experienced therapist where we're not so much we're talking about me, but we are talking through how to process this myself so that I can accept these heavy things and put them down and ultimately help the other person figure out how to put their stuff down themselves.
Talking about the coach's coach.
Yes, coaching the coaches, absolutely. Yeah. And that was sort of the special key to all of this. And I've been, because it was very heavy. I would get off some of the phone calls and cry, but also as a psych nurse, I was accustomed to not quite their level and that content, but I was very accustomed to hearing heavy things. So I had experience sort of having my cry and then walking away from it. But
yeah. So what are you doing with all this information as you're gathering it? I mean, it's just because it seems like there's research, right? And then there's just like, there's no end to this. Like there's no bottom to this. Where does this go as you're collecting it all? I mean, are there patterns? Are there things you're going, wait? Like some of this stuff seems really obvious. And some of it is like, why hasn't anybody ever, why didn't I learn any of this through my master's degree, or any of that stuff? I mean, what can you tell me?
So the only thing I was collecting with any purpose was the theme of what we talked about. And it wasn't the themes, anything related to war. It was like, I'm asking them, what does your community need? What are you seeking? What's an unmet need? So I was literally tallying like, oh, this guy talked about chronic pain. And this guy talked about trauma symptoms, not just PTSD, but like nightmares and things. That's all I was collecting. And so after I talked with about 100 guys, I had a very clear pattern of what they were seeking. And then I was able to actually figure out what I was going to do.
Okay. So before you get there, how was this, or maybe you didn't, I don't know if you asked this question or not, but how is this different than maybe what they had previously experienced through, as we're just talking about SEALs right now, like through the Navy? In terms of psych evals, or maybe that's not the right term, but more of like an evaluation or an assessment or some type of a counseling appointment or therapy appointment. What was the differences or the missing pieces that you were picking up? I don't know if that's the right question, but I think you probably hear what I'm trying to ask you.
Yeah. So a lot of guys, whether they're tier 1 or tier 2, are required to go see the psych. And what doesn't matter if you're Army Special Forces or Navy SEAL or whatever it might be. So you are required to go see somebody with some frequency. Higher your tier, generally, the more often you have to go. But what those psychs are very concerned about is, are you fit for duty? It's a little bit different. You can still go talk with them. And I encourage guys to go talk with them, because here are these people who are free and at your disposal on your base in your same time zone. But the concern is sort of fitness for duty, and are you deployable, and are you safe, and all of those things. A lot of guys were telling me, like, I ask guys, like the way I ask if they're suicidal, I ask them that, but I also say, like, are you safe with yourself? Is your family safe with you? Are you safe with your family? And a lot of guys, when I ask them that question then and now, they cry frequently the first time I ask, because they're like, well, no one has ever asked this before. And it's not that the people that they talk to don't ask. It's just in a very different way and in a very different setting.
Very interesting.
Yeah. The people who are in base, in my mind, they are there and they're very good at the job that they're there for. So
I hear what you're doing right there, and I appreciate it. And so I'm going to say something with a little bit of like code and disclaimer too. But it's also, I don't know the answer to this question, but this is what I've been told. So this is all I know. And that is, my understanding is these evaluations, whether you are SEAL Team 6 or you are working in the motor pool, it's the same stuff. Is that,
I think so. True? To a certain extent. Yeah.
So the only difference being the frequency in which you are required or asked to sit through this, it would be the major difference.
I mean, it is different for the operators, for sure.
Okay.
It is different because, of course, like the psychs have more insight into what they're doing in the field. I will say that I work with Army psych, and they are like amazing.
Oh, that's good to know.
Like, yeah, like Army is totally different than the other branches. It's like it's sort of different in each branch and like what they're asking. It's a bit non-standardized. So I hear different things depending on what I'm just going to call them dudes because I also work with women. Everyone's a dude.
I think it's fair. Fair.
But the dudes tell me all different kinds of things, and it seems to be kind of different.
Okay, so let's go back to that. I took it down a little road there, just coming back. So what are the things that you're learning? What are these patterns that you're seeing? What can you tell us? Like, what are the big pieces, the big chunks that you're taking away?
Yeah, so the top two things that were basically tied were trauma symptoms. I'm just calling it trauma symptoms, hypervigilance, nightmares, all of that kind of stuff. So trauma symptoms and chronic pain were 1 and 2, and neck. After that was like sleep and like sexual dysfunction and like, sort of like there was nothing surprising. It was all the stuff that you would expect, at least now that I would know to expect, and all the stuff that has been published, like with operator syndrome and is out there and known about operators and the stuff, their physical health symptoms.
Yeah, but were they putting this together? So going back to like trauma symptoms, and you kind of, I don't want to say you glossed over it, but you kind of went over that fairly quickly, like the hypervigilance, the lack of sleep, right? Moodiness, there's going to be the up and downs there. And then you went into things like, there's probably depression that comes up here, and then sexual dysfunction. Are they putting this together? Like like, is it at all? Is it intuitive for them at all? Or they're just going, well, I just thought I was fucked up. Like I didn't recognize that these things are compounding on one another. Like, what can you tell me there?
Oh, yeah. So guys would be saying things to me like, I'm speaking for myself, but I'm also speaking for my community because everyone I know is only sleeping 3 hours per night.
Got it.
So it's happening to me. It's happening to them.
It's normal.
The sexual dysfunction, of course, was discussed significantly less. But guys would be reporting that about themselves. And like if I happened to talk to a medic or I happened to talk to somebody who just was kind of in the know, they would tell me, oh yeah, like I'm not the only one with erectile dysfunction.
Got it.
So,
okay.
Yeah.
I mean, I'd have deeper questions about like that. Are we saying that so that we can get blue pills, or are we actually, is this actually an issue or anything like that?
It's a big issue. It's huge.
Okay. So, I mean, those are questions, right?
Yeah,
so,
yeah.
All right. So with all of those things, all right, so you're kind of putting all this together. 1 and 2 were the trauma symptoms very broadly, right? And then 2 is chronic pain. And generally speaking, with those kinds of things come other things. What I mean by that, like with chronic pain comes the use of substance or medication or whatever. What can you tell us there?
Yeah. So with chronic pain comes a whole host of things. Chronic pain is super interesting. I ended up doing my doctoral research on chronic pain and trauma symptoms among SEALs. And chronic pain is really interesting because after about 90 days, it's super individualized per person. That pain signal is basically creates a home for itself in the brain.
Yeah, it's hardwired now, or it's downloaded onto the motherboard, and it's not going to go away without some serious
Your
work.
brain starts remodeling itself to maintain both the chronicity, the length of time that you have the pain, as well as the severity of the pain. And when you, in particular, have trauma symptoms, they go hand in hand. But with the chronic pain, you absolutely end up with substance misuse. I'm not talking about addiction. That's a separate thing, but substance misuse. You end up with all kinds of sleep problems because you can't get comfortable, or you're taking meds, or you're using substances to overcome issues with
cocktail
pain.
Of stuff
And it's, pain is like this self-fulfilling negative cycle in your life. So affects all things. It affects erections. It affects your sexual interest. I mean,
your drive to work out, your drive to do anything.
Kinesiophobia.
Yeah, exactly.
Yep.
All of this stuff. Like, you just want to be, I mean, again, I think my conversations with people, and I've had several of them on the show, that's what's important for me, I feel compelled to continually put this in front of people as not all the time, but to remind people, hey, there's some shit going on out there that we need to be aware of, and there are answers to your problems. So that's one of the reasons I wanted to have you on today. But the bigger thing here is people not understanding how that cocktail impacts them for the long term. And the things that you hear them talk about are often associated with all the things. It's never one thing, it's all the things. And that's what I picked up, like the wanting to self-isolate and, just not wanting to be around people, friends, whatever. And that is not just one thing. There's generally other things coming. Maybe it is for a small percentage of people, but it's this compounding effect of stuff. And obviously, if you're caught in that sticky web, it's very tough to untangle yourself out of, particularly without direction, support, and what does I would imagine, what does a Navy SEAL want? First off, they want to know that they can do it on their own, right? At some level, because these guys are independent, resilient, self-reliant type of dudes. Number two, what's the instruction manual for this, right? Is there is there a start and stop? Because I can figure this shit out, right? What's the reality of that? What are you figuring out in this process that these guys need to help themselves?
Yeah. So once I figured out what the top two considerations were, the guys who allowed me to keep their name and their telephone number, I went right back to them because I had done like sort of a scientific literature review to figure out some things. And I figured out that if we treated either chronic pain or the trauma symptoms in a kind of specific way, it should break the cycle of chronicity and severity of both. Treat one, treats both.
All right, so how do we do that? Like, I'm dying to know. Like,
isn't that the question? Yeah. Typically through education. That's, kind of the way to do it.
So there's no magic to this.
There's no magic. There is hard work. There is work, but it works beautifully. So I just asked the community. I went right back to those guys. I said, hey, so I discovered this thing because they're all saying non-invasive, no pills, they want to continue operating. However, the treatment, they want to be able to kind of take it with them. There were, really predictable things now to Rebeca now, 7.5 years later. So I worked with members of the community for about 1.5 years, 2 years to develop what we were going to do. And I essentially put a group of former SEALs and a couple of UDT guys. So like Vietnam era, Korean War era dudes, super cool. Smart. Through education, period of education with me about targeting chronic pain, but I had also gotten trauma readings from them, trauma scale, scoring how severe their trauma symptoms were, and didn't tell them at any point, hey, if you like these skills, apply them to your trauma, but they did it anyway. Because that's usually how operators are. You teach them to fish, and they're going to like revolutionize the fishing pole, and they're going to discover a new way to fish. And it's
they're going to be the best at this shit.
Yeah,
like absolutely. I'm going to be better than
right.
Everybody. Yeah,
so that's what they did. They were like, hey, this is a really cool new coping skill. I'm going to try it with my nightmares, and suddenly they're nightmares. But also like I said, in the brain, the intermingling of chronic pain signals with mental health related signals is strong. And so frequently, if you can sort of sever the connection in some way, you are also going to see a decrease in your mental health symptoms as well. It's sort of a specific way of doing it. I'm not trying to be coy because it's like a whole 3-hour thing for me explaining this, but very specific kind of approaches in psychiatry, psychology can really help the two separate, and we achieved incredible success.
Yeah, so I think one of the important things here is you're saying what you just said. I'm so glad you just did that, because I asked the question, so how do you do that? Yeah. I think everybody wants okay, so give me the answer, right? And I think anybody that listens to this show that's been anywhere near this community and the broader spectrum, it's like asking somebody how to do, what's the best way to do CQB. That might be that might be a really stupid example, but it isn't. I don't think it is. There isn't going to be some magic, and this isn't a process you're going to learn in a 75-minute podcast or something like that. But So I appreciate you putting that out there, because I wouldn't expected you to say, "Oh, well, it's these 3 steps and everything's fine. It works and
Right.
you're cured," whatever that fucking means.
Yeah.
But okay, so you're learning this stuff about the chronic pain, particularly as standing alongside the trauma symptoms and how they intermingle. And I love what you said there about just making people aware that this stuff begins to download itself onto, as I described it, like the motherboard, and reprogramming that takes a lot of work. It's physical, it's mental, it's emotional. Sometimes there may be involved, you may involve, I'm sure there's other maybe specific therapies in the process that you go through, or modalities. There's no one size fits all to all of this. I'm sure you've got to assess, this could be the right treatment for this particular person. And so we're going to give that a try, but there's no guarantees. There are some alternatives. We will see when we get there. So you have to do the work in order to know what work to do, or what work there is to do next. I wonder how that process has gone for this community, and just in terms of the success rate and how we're sort of measuring that. Can you talk about that at all?
Yeah, so you are hitting on all of my high points for why I like working with special operators so much.
Because they like to win. They want to know what the score is.
They do. But they're also extremely creative. They are also insightful. Their brains are literally programmed in such a way, if you put them on a functional MRI, they're using their brain structure slightly different than the typical person, and it literally provides them a little more insight and control into their own physical processes. But point being that these guys are innovative. And if you tell them, hey, this is a process, stick with me, give me your time, give me, whatever, let's figure it out together. Let's collaborate. These guys will want to do that. And so I find a very high success rate, not just with chronic pain and trauma, but generally with mood and suicidality and all of those things with these guys, because I just approach them from this place of like, yeah, I know, I get it. Like, you've tried 8 different things with your other providers, and now you're with me, and things are pretty severe and excessive, and they're spiraling and all this stuff. But like, we're going to do things just totally different, and it's going to be a process. And I'm going to just meet you wherever you are. And I, at this point, understand your community. So we're just going to be really innovative, but you have to work with me. And so we will do a lot of trial and error. But
yeah, it's interesting. It's sort of like it's I guess like modern Western medicine and the process that people go through to finally get to like a rock bottom point where they're like, dude, this basic protocol is not working. And part of what you're saying there is what you've learned is these special operators, their brains function differently. We're going to get back to the brain stuff here in a minute, but they function differently. We are not the same, as they would say. Like, we're not the same.
No, their injuries are different. But so therefore the treatment has to be different. It's like somebody who has, it's like somebody who is, there's 2 people who have back pain. On paper, they're the exact same person. Maybe they were both involved in a motor vehicle accident. And however, and they both describe the back pain the same way. And therefore, so everyone's like, oh, the treatment must be the same if you just look at them, read their medical record or whatever. But actually, their injuries are completely different. And completely different injuries can cause the same symptoms, the same human experience, lived experience. And the operators are under completely different stressors. They have totally different injuries, different causes than the typical general population research. So, of course, general population treatments are not typically going to work. Sometimes they work, but most of the time they don't. So we have to go to something completely different.
Hence the getting to this, you've been through 8 other practitioners at this point, and you're finally with me, and they have to put their trust in you to go through some other new process.
Yeah.
Help me out here on this one. As a nurse practitioner, I don't know where this fits into your practice. Are you able to prescribe medication?
Yep.
And how much of that plays into this, and at some level on the maybe the SSRI side, or maybe pain management side? What can you tell me here?
Yeah. So as a nurse practitioner, so I'm licensed in Washington State. I can diagnose, prescribe, order tests, do all kinds of things up here independently. However, I work with other people. I sort of work in sort of a consortium. I know most of them through Seal Future Foundation. Shout out to them. But I work with other people who also specialize in working with operators. So if I have guys come through my practice, I very rarely prescribe. I think I've prescribed to one guy, and I didn't even directly prescribe to him. He had a very specific thing going on while he was on deployment, and I was able to help him get very short-term treatment at his forward operating base, which was a whole different thing. But I don't prescribe because these guys don't usually want a drug, or if they do, what we're really looking at is an endocrine problem. So I'm going to send them to an endocrinologist. So I very rarely prescribe to them.
This is why I asked the question. Sort of the back end of this in my head was, I would imagine in most cases you're trying to get them off medications, right? Like you need. Yep. Look, you take the life jacket, you do the things. There's all that stuff, but by the time they get to you again, going through 8 practitioners, the VA, the assessments, the however many psychiatrists, psychologists, other practitioners that they've come in contact with, they can be walking in with literally a bag full of medication, right? That or medications they're supposed to be taking, some of which they may be taking, some of it they might not be, and all these other things. So I only ask that because I think that is a big fear for people. Like, I don't want to go on pills, and to treat all this stuff, and that's all they want to do. I use that in air quotes. It's all they want to do. They want to throw meds at me. So I wanted to ask that because I think I remember you talking about this, the particular the pharmacology piece to an extent in a very very broad sense when I heard you present. Let's go back to the brain stuff here for a minute, because when we go back to the injuries are different and we are not the same. One of the I imagine your research is going to it begins to expand. It has to, because you start to learn all of these things to try to problem solve, and you're starting to recognize things that you had learned about or probably heard about or whatever, but don't necessarily get maybe brought up in general practice because okay, so we have somebody that goes through, as an example, goes through in a car accident, it has a TBI. Okay, that's very specific. How often are we dealing with that versus guys that are exposed to TBIs daily, multiple times a day?
Yes.
And whether they understand it or not, and how does that, when does that start to kind of arrive for you, and where does that go? That's the best I can do with that question. Sorry.
Okay. So there is this incredible sort of thing that we say in medicine. The way we have to train medical providers for the general population, because who the heck works with special operators? Like, not very many of us. Yeah, right. Like very, very few of us. That's like a sub specialty. So we have to train people who provide healthcare that when you hear hoofbeats in the distance, you have to think horse. And sometimes it's a zebra, maybe it's an antelope, but it's one of those animals that, kindergartners know about. Because you have to know, okay, if you see this particular, group of symptoms, of course, we're going to immediately think depression. And of course, we're immediately going to start thinking about serotonin and dopamine and glutamate, like these really, okay. With special operators, I think, is it like, a unicorn? Is there a fairy riding the unicorn? I mean, seriously, is it
what's the half man, half horse? What's the half man, half horse?
I'm bracing myself for this thing that's going to come around the corner. Right. And that is truly the situation with these guys. I have guys who have been, they're out shooting. My favorite weapon is the Carl Gustav. And yeah. So I work in Blast TBI. That is that's where I do a lot of my research in neuropsychiatry. And so Blast TBI. So I basically talk about like guns and charges and eating charges all day, every day. And like, how many civilians eat charges all day, let alone of a Carl Gustav? How many guys or how many people in the general population are doing combatives and blocks of combatives training, and then blocks at the range, blocks of weeks of training at the range? Like, So we just are not trained to meet the needs of people in these like very specific populations.
So it's interesting. I was just down. This is maybe a lame story for people, but I've been to the Blakely training facility. It's called the Arena down in South Georgia, and they have a breaching facility there. And I was talking to Ed Nolan, who runs the joint. He's been there forever. Eddie's an old Ranger. I think he's from the 75th Ranger Regiment. Anyway, the point of that being is they have the breaching school that comes through there, and I think they're there for like 3 or 4 days. Or maybe it's like 5 days. It's not a full week. I know that because they were doing it when I was there one of these times. But they hang 36 doors in the time that they're there. So that what I'm saying is that's 36 explosions that they're dealing with at different levels using all different kinds of stuff. This group of guys, obviously in close proximity, just in that 3 to 5 days of training there, so then they can go out and do some more training somewhere else and whatever. So again, the volume and frequency of that stuff is how would a GP somewhere or that works with the general population have any earthly idea on what to recognize or what to think about there? It never even comes up.
No.
It wouldn't even come up.
Yeah. No, I don't blame them. I mean, if you plopped me in like an emergency at this point in like an emergency department in like, the middle of LA or like San Francisco or something, and you said, "Oh, Rebecca, you're now the psych attending for tonight," I'd be like, "What?" I could hand out some SSRIs and do all the assessments. Of course I can. But like that is a different universe than what I do. So I really don't blame anyone in healthcare who has, a Green Beret or a Navy SEAL show up and they start, and they talk about blast and the effects of blast and and the healthcare providers are just looking at them like, I don't know what you're talking about.
Yeah, I'm sure that's a problem, but they don't know. So neuroscience is the thing. And I nerd out on it too. And I know a little about nothing. I'll just say that. When it comes to that stuff, it is a deep, deep rabbit hole. So the question I guess to ask is like, what do you want people to understand about these TBIs as it relates to all the stuff we've already talked about in terms of the symptoms and of trauma and the pain stuff and the work that they need to do to overcome this? And can they? And, again, you can't give them, I'm not asking you for all the steps on the podcast, but what do you want them to know?
So regardless of whether you are, what kind of special operator you are, or if you're just someone who eats charges all day, because that is literally whatever your job is, guys who train SWAT to do breaching, to do whatever, we see a very similar syndrome. And that is called operator syndrome. And what happens over time is that these dudes are exposed to years of chronic stress overload, just physiological stress and psychological stress. And it comes from a variety of origins. There's, sort of like that psychological stress, especially for the operators coming and going away from their family, all of those things. There's physiological stressors, there's injuries, there's exposures to things, cancerous things and just things that affect their neurological system, all kinds of exposures, as well as, of course, the blasts. And all of these things, most basic way of explaining this is all of these things over time reset your internal baseline, your homeostatic state, all of your internal processes, your heart rate, your blood pressure, your breathing rate, just 3 most basic things, as well as your endocrine system. All of it basically gets reset because you are in stress overload for so long. And when you're very stressed out, you have a higher blood pressure, you have higher heart rate, all of these things. And eventually your brain is like, oh, this is normal. So I'm just going to reset myself to maintain the chronicity and the severity of your stress. And once that happens and your brain reorganizes itself, everything else is going to reorganize itself. And that means that your endocrine system is going to change, as well as your mental health. If you have any pain, you're more likely to develop chronic pain. All of these things are related. It's just all related. And unfortunately, then it combines with an inability to find relief. And it just kind of becomes this really negative cycle. And of course, the blasts and the physical injuries create physical injuries internally also.
Okay, so this is kind of what I was gonna go with this. So you're talking about the parasympathetic, the basic bodily functions that we don't have to think about, your body does, which then impacts the sympathetic, right? Which then, so in the internal stuff, or let's say the physiological always precedes the physical. So that stuff starts, unless obviously you have an acute trauma, right? That's a different deal. And what I mean by that is you got a gunshot wound. All right. There may not have been anything physiological before, but obviously you've got a physical injury now. But what you're talking about is a combination of the two, and like two trains crashing into one another at a completely different level. And that's the way I kind of look at it. I go, this is a recipe for disaster, especially if we're rewiring things. I think the other challenge that exists here is that the more you become programmed to this, it's what's the word I'm looking for? Like I don't want to say you're rewarded, but that's good, right? It's kind of considered like, oh no, man, I can do this. This is no problem. Like I can eat that thing. Yeah, it was just another one of those, kind of thing. Like I got blown up again. Big deal. Like how many of these have I gone through? Or yeah, I fell out of that thing, out of the back of that airplane, or whatever the case is. And it's just like, this is normal. And it's not like it's just normal. We're just saying that. Like it's literally been hardwired. Like, no, it's normal. The pain that I feel, the shit that I'm going through, and
everyone else is experiencing it too. So it's like a shared social experience.
Yeah, that's what I'm saying. Until it becomes a problem and it manifests into some other physical things or psychological things that they don't understand. Like, why is this happening to me? Like, this was good for me. It made me harder to kill, or whatever. It made me better in the, when I was downrange, if they want to call it that, or whatever else. But now it's a fucking problem because I'm home. I'm not in that situation anymore. And, they're blaming maybe themselves a little bit, but also the people around them for not understanding them. When the reality of it is nobody really, maybe at the time, nobody really understands them, including themselves. Because of these things that are, again, this journey you're on and learning all of this stuff along the way. I think that's really fascinating. But I wonder, as we kind of maybe move into the next thing, is like, how does this stuff contribute to the next thing? You mentioned suicidal ideations, but particular suicide, which is something that you deal with quite frequently. Can you talk about that?
Yeah. So let me back up for 1 second and say, so a lot of young dudes, will think that constantly being amped up and upregulated helps them survive. And actually that is the opposite of what needs to happen. Your old men in a young men's profession are some of the calmest dudes you will ever meet because they're downregulated typically. They're able to downregulate before they go out on a mission. And that is what keeps them alive. That is actually what keeps them alive. So a lot of these guys who come back who are upregulated the whole time, they didn't keep themselves alive. The people they were with kept them alive. Wow, and they'll figure that out. Yeah, they'll figure it out.
That could be a tough pill to swallow.
Yeah, if you go into, you're out on a mission, you're looking for the bad guys, we don't want you upregulated because your SA, your situational awareness narrows. You might see this guy ahead of you, but you don't see this guy. And it's not just that you didn't turn, it's that you are literally tunnel focused because you're so upregulated that you're going to miss this guy over here. And so a lot of guys after maybe their first deployment, or maybe at some point during their first deployment, they'll start catching on that they actually need to enter missions in a more downregulated state.
So is this something you help them practice?
It is.
Yeah, I'm sure.
Yeah. I get a lot of guys who maybe come back and they're in a constantly upregulated state. They're sort of we call it disinhibited. They're risk-taking. I get a lot of guys at that point and we start talking about things and trying to figure out how we're going to downregulate them. Yeah, and it's not just me. I send them out for special treatments and things like that. I'm not.
Yeah, so that's what I was going to ask. Like the behaviors that manifest. You mentioned the risk-taking. That that's a lot of different things, whether it's riding a motorcycle at 1,000,000 miles an hour down the freeway, where it's getting involved in extramarital affairs, it's
unprotected
substance
sex
abuse.
with people that you don't know, going out and drinking more and more, potentially showing up at work drunk or under the influence of something else. Yep.
So obviously you have to deal with that too.
Yeah.
In your conversations, and I wonder how much of that is part of the practice in helping somebody. Like
Absolutely.
I mean, there's behavioral therapy, right? And then there's also marriage and family therapy, that happens. I mean, where does that fit into all the things that you're doing?
There are also strategies and treatments to force a downregulation. I can send them for bilateral stellate ganglion blocks, which is very frequent. Yeah.
What is that?
Oh man, these are awesome. This is old. This is old medicine that has been repurposed.
Interesting.
So essentially, usually an anesthesiologist or another physician. I don't do this. There are nurse practitioners who do this. I don't do this. I send them out. Typically doing anesthesiologist like Sean Mulvaney, Dr. Sean Mulvaney. People can look him up. And he will inject an anesthetic bilaterally into the base of the neck where there are nerves. And within a fairly short period of time, minutes to hours, their sympathetic system will downregulate. It will force a downregulation into a parasympathetic state.
Is this so the injection site, I imagine, correct me if I'm wrong, but this is impacting the vagus nerve?
No.
Okay.
I'm trying to remember actually. I
It's
don't
okay.
remember.
We don't have to get into
Let me
that.
just say I don't remember.
We talk about the vagus nerve and how it impacts parasympathetic.
Right. This is it's like day 1 you're injected on this side, day 2 you're injected on this side, and between the two there is a down regulation. And sometimes guys will feel it after day 1, and then they go in for the second one and they're fully down regulated. And what we will do beforehand is sort of talk through how we are going to maintain it. Creates, because of the downregulated state, it creates space in between a trigger and a reaction. So it's really good for guys who are upregulated, who are maybe impulsive or very angry, rage, things like that. And we'll figure out how to sort of maintain that pause. That's like sort of my primary go-to for downregulating. Now that will be like a first thing. And then there's other things too, ketamine, various things.
Sure.
But, depending on if they're active duty or not, they might not do that. But I will say the U.S. Army Special Forces send their dudes to a guy named Dr. Eugene Leapoff in Chicago. And their active duty guys will get bilateral stellate ganglion blocks. So this is not a totally crazy thing.
Yeah, it sounds fairly uninvasive. I mean, we're talking needles here, but you're not going on a prescription narcotic or a medication that's going to take some time to take an effect. We really don't know what that is. Once it's in there, we can't get it out. We need to let the body metabolize. We got to figure it out and all that stuff versus this is fairly fast acting. We're going to know really quick whether or not it's working or not. And it's not, from the long lasting effects, it's your body that's maintaining this, not a drug that's doing it for you.
Yep.
I think that's interesting. I had no idea that's a first for me. You mentioned something there about like, what can you do when you're still operational versus when you're not?
Yes.
And obviously that is a big concern in going through any kind of a treatment or therapy is like, what red flags is this going to send up the flagpole that's going to keep me from doing the thing that I love and want to do, which is number 1, do the job. Number 2, be with my guys and not quote unquote abandon them for my own personal, selfishness because I'm having a bad day kind of thing, which is ridiculous to me, but I also understand it, from a team perspective. So, I mean, I went to the brain thing and then we were talking about parasympathetic, sympathetic stuff, all the things that are, going all the way back to the beginning of kind of where you started with this and the collection of information and a professional that understands how all of this stuff intermingles, again, a sticky web and trying to untangle it.
Oh, no.
And then again, the next part of this is like, it's not just one person, all of this stuff is impacting a lot of times as they get, older or whatever. They're not 25 forever. I wonder what the age range of guys is. Can you say what the sort of the general age range is of guys that you're working with versus how it looks, across the board in NSW? I mean, is that a question you can answer?
The guys I work with, I get guys. So I also work with Army a lot now. It's entirely possible I actually work with more Army guys presently than I do Navy. So that has changed a bit. But I work with guys. I mean, if I mentioned before, like pre-pipeline, so they're pretty young usually. But most of my guys who come through my practice are somewhere between 28 and like 58.
Wow,
and I have some older guys too.
Yeah, so there's going to be a lot of liability in there for people at different stages of their life.
Yes.
Kids, wives, relationships, homes, assets, all the things that get impacted when you're messed up, right? And when I say that, I just mean you're not whatever's going on isn't even keel. It's tough to balance all of those things. That's pretty broad. That is pretty broad. I wonder, are there large distinctions between how the 58-year-old, handles himself versus how the 28-year-old handles himself? They're just dudes. There's
differences between the branches.
Okay. Can you talk about that? I want to hear.
Yeah. So the way I describe this, so just to be clear, I work with some Marines, I work with some Air Force guys, but like I have to work with enough dudes from one branch to like really be able to like speak to that branch. Yeah. So I can really speak to like Navy and Army. And the way I describe it is my Navy guys are like supernovas, and they burn bright, like white hot. They are.
I'm laughing, man. Everybody listen to this.
They are like supernovas, and I mean, I love it. And like, one is not better than the other. I'm going to describe them totally differently. So my Navy guys burn bright, and they are sort of like, big personality and a lot of fun. And they have typically when they come in, it's something that is very dramatic, more dramatic presentation. And
can you explain that? What do you mean by more dramatic presentation?
Dramatic is a good way of describing. Yeah. They have sort of anxiety. They have a lot more suicidality.
Got it. It's like a different level of severity.
Yeah.
Like a severity level. Maybe?
Yes. Okay. But they're also like my poets. And like a lot of my SEALs write poetry, and like they would never tell anyone, but like they write poetry, they draw, they're artists, they play musical instruments, they do like these like super artistic things. I
know way more SEALs than I know Green Berets, like just in that sense, or anybody that's worked in any other similar Army units. And yeah, you nailed it. I mean, they all do those things. And I find out about this stuff later after I've met them.
Yeah.
And so what you're saying, it hits home. I get that. Yeah.
Yeah. And then my Army guys are a lot darker. They are my dark dudes, and they tend to have more like chronic stuff going on, sort of a chronic low level depression. Sort of a chronic, their suicidal thoughts are darker and just more sort of chronic and grinding than the SEALs.
Can you put your finger on this? Is this a cultural thing? I mean, are there any answers to that? Like, what?
No,
why?
I mean, you have to kind of look a little bit also at the personality of the various branches, special operators. But I'm not really sure. And it's all ages. And I mean, like the Green Berets that I work with and the other guys and other units, they're still very creative. They may also be writing poetry and drawing and like doing all of this stuff. But also like my Green Berets are more like loners, and they're readers and they're woodworkers, and they do things that are very individual in nature and more isolating. Mm-hmm.
Gotcha. Is that helpful in the treatment, or is it harder? Is one harder than the other? In your opinion? I mean, I don't know if it's a fair question or not.
No,
I'm not trying to pit the Navy.
No, not at all. Not at all.
I'm just saying. I'm just asking.
No, I think it's just a totally different personality to work with, and frequently the same treatments work for both of them. So, because we're looking at very similar injuries and we're looking at a very similar lifestyle. So, the treatments are about the same for Navy and Army, and it kind of doesn't matter. It doesn't matter if they're my darker guy or my supernova guy.
Interesting. Can we kind of maybe switch gears just in terms of guys that aren't maybe Navy, Army, but you mentioned other 3-letter agencies? I mean, every police department out there, whether it's state or municipal, has some level of, emergency response team, SWAT team, HRT, something like that, that happens. And I wonder about the compare and contrast there in your experience with regard to similarities, differences between guys like that, people that are in those units, or in those special operators versus the other guys that we've already been talking about. Can you make a distinction there at all?
So I work with lots of guys who have gone through SWAT and maybe have gone to one of the agencies and sort of worked, more like local SWAT or whatever. It seems like it takes them a little bit longer to get to operator syndrome and to this chronic stress overload and like sort of the predictable injuries, but they get there.
Yeah, that kind of makes sense to me just based on, the term would maybe be op tempo and the, the intensity of, within the volume.
Training and
all of that, deployments versus no deployments. This is an everyday job versus, you're away for 6 months and it's 2 times, 3 times a night, kind of thing versus we do this over 365 days and the intensity isn't quite the same. We may not be blowing up a door, maybe we do that once a week, but we do go to training, which lasts a week. So you get these kind of fits and spats of how those, at least the physical, maybe TBI stuff comes up. But I wonder about the other stuff though, the other things with regard to, I guess once the trauma does present, right? And or the chronic pain presents based on the things that they may or may not have gone through. Is that the same? Or is it different in some way?
So specifically regarding PTSD, I can speak to that for sure, that it can be different. So special operators tend to have very high trauma scores. They do not actually meet the criteria for PTSD because they don't avoid anything. They don't avoid things, and there's some other nuances. So it's more likely, just in my experience, for people who have gone up through police and first responders into the agencies, they could have the same symptom presentation as someone who's come through the military special operations and be doing the same job and same symptoms. And like my dude who comes up through like first responders is more likely to actually have PTSD versus the operator who has very similar symptoms. So there's that difference. But generally speaking, it's very similar. And I still see that experience of like trying 6 or 7 different things. And then I do what I do with the operators and it does work for them. Okay. They just tend to actually meet the criteria for it. But you definitely see the treatment resistance. Chronic pain, it's basically the same as the operators. A lot of the other stuff is shared. So,
there's a question I forgot to ask earlier, just with regard to the TBI stuff, when we were talking about blasts, and I think, and you'd mentioned different charges and eating charges as a sort of nomenclature there. But I wonder just about gunfire, with guys that spend a lot of time on the range,
pistols,
particularly, anybody that's done this long enough knows not all ranges are created the same. There's indoor, there's outdoor, depending on what you're around,
berms, is the ground wet? Is there a roof over you where you're shooting?
Yes. Talk about all this and how this can impact people and what can people do to be aware, but also prevent these things from happening, and who is at risk, who's more at risk than another person. I know a lot of firearms instructors. This is what they do. They're on the range 5 days a week or more, kind of thing. Like what do you want them to know? What can you tell them?
Yeah. So any blast is blast. Doesn't matter if it's coming from a 9mm. Doesn't matter if it's coming from a 22. Doesn't matter if it's a 12 gauge. Doesn't matter if it's an AR. That like blast is blast is blast. And if it's a smaller caliber, then yeah, you will probably need to be exposed to more to get the same experience. But it really doesn't matter. There's so many other factors with where you're shooting, how often you're shooting, and your personal biology. So the same amount of blast will affect everyone differently. And the thing that I tell guys to look out for is feeling punch drunk, sort of that giddy. Maybe you see a guy who's new to the range and they're out there and then they've been shooting for a while or whatever. Maybe it's day 2. Maybe they're doing like a weekend warrior thing at the range. And suddenly they just start doing some weird stuff. Like they put their weapon down and you're like, why'd you just put that on the ground? And they walk over to their bag and they're like trying to look through their bag and then they can't find their gun again. Like that is a TBI. That is blast affecting their brain.
Wow, I think a lot of people would reduce that to that guy's just a fucking idiot and he needs to be kicked off the range. He shouldn't be here. And what you're saying,
he shouldn't be there. But
he shouldn't be there. But we should be thinking about like what are the reasons this guy is behaving like that? Is he just an idiot, which is very reductive.
Totally possible.
And maybe that is very true.
Right.
I've seen assumed a lot of that before in a few occasions, but also this could be something deeper and we need to be taking responsibility for recognizing it. That's fucking interesting. I'd never thought of that before.
Yeah, especially someone who's brand new or someone who really hasn't been exposed to much. We see potentially some resilience with the brain after you've had a couple experiences like that. It requires more and more blast to actually give you another mild TBI. But overall, if you have someone who there's a change from their like functioning baseline, that they just seem weird, like they're, and it could be anything, they're happier, they're darker, whatever, that is generally like, let's make an assumption that is blast affecting their brain.
Wow, interesting.
And they need to be removed from the situation. Because if they have a mild TBI from the blast on day 1, and then they go out on day 2, and they were either still symptomatic or their brain hasn't recovered, and they go out on day 2, that is now a compounding TBI. And their symptoms are actually going to escalate. And this is what happens with block training in the military. And it's the same thing when you have like a shooting event over several days and you have people there. And like by day 3, people are acting weird. And then day 4, they need to be removed from the range and I'm not like, and this is like me just sort of saying like, that's what would make the most sense, but that doesn't make sense for the military, for SWAT, for anyone who's training, obviously. So how my role in all of this is, okay, so if we can't change the training and we can't change the exposures, what else can we do?
Right. And what's the answer to that? So if you're going to be, maybe you have answers for this. I don't know. I mean, I've done a little reading on this, but let's just say for average guy that's out there on the range very frequently, when I say average instructor or average student or law enforcement officer, team guy, whatever, who's training quite frequently, are there things that you can do to minimize the impacts of the volume and frequency of the exposures that you're going to get anyway? This is if we can't change these things, what can we do? Is there specific ear pros or specific practice that we can go through to maybe help with this?
Yeah, absolutely. So I recommend anyone who goes out and trains with frequency, buy yourself even a cheap blast gauge and wear it.
Oh,
so
interesting.
That you actually know how much blast you are experiencing.
So it starts with awareness.
Yeah, absolutely. Be aware. There's a ton of research happening right now. It's going to be published very soon. I'm very lucky that I know these things because I'm in the community, but I think that there are going to be actual numbers published coming up fairly soon on how much is too much blast for a single day and for a cumulative effect over time. So the very first piece is awareness. And I unfortunately didn't think to get a blast gauge before I went out to that shooting event that I sent you pictures from.
Yeah.
But I wish I had. But first thing is awareness. The second thing is maintaining whatever safe distances you can. Don't put yourself in the line of blast if at all possible. I know that's not possible or realistic most of the time. But it's very much the idea of like the X-ray techs, go behind a wall and, do all kinds of things to just mitigate best they can.
This is behavioral stuff that anybody could do, right?
Yeah,
Just being aware
if
of like
possible.
when
And again,
possible.
like I am aware that this is not realistic in all circumstances. I get it. This is just what I do know. The awareness that if someone is changing from their baseline, if at all possible, just to get them off the range for the rest of the day. Even if you can just do that, give their brain some extra time. I do know that like in the military, there are people who are trying to change the way they do training so that you don't have more than like 5 days in a row on the range. Maybe you do a week of range training and then you do a week of something else away from the range. And then you do another week at the range and whatever it might be. And also just general awareness of there's all kinds of information resources available online of, is blast worse? It is in stairwells. Is blast worse if you're on wet ground? How close are you to berms? Where are you standing in relation to whatever you're firing? There's all kinds of information available. And I think just sort of checking that out ahead of time and being aware of just being smart. And, where can I stand where I can still see everything and still give really good instruction, but maybe it's not like right next to them on the right side, slightly behind them. Maybe I should stand in a slightly different position.
This is what I'm saying. Yeah. I mean, when possible, these are very easy things to do, right? If you're being aware of it and you're just like, I'm just step back 3 feet and how much, check your gauge at, level and then back 3 feet and see what it says. I love that. This is fascinating. I'm anxious to get this out and see what people's reactions to this are. I could see people going down there, oh, this is going to be awful. This is going to change our training and we're not going to be able to shoot as much because departments are going to be covering their ass. Or we just behave a little bit differently and we show the good side of what we're doing and how this is potentially helping people. I don't know. I don't want to go too far down that road. I have something else to say about that, though, in terms of suppressors and things like that.
Use suppressors whenever you can. Just common sense stuff, which I know that departments and people don't want to buy suppressors because they're expensive.
Oh, no. So here's the deal. I'm having my attorney call you as my expert witness when I go and sue Gavin Newsom and Rob Bonta's ass for not letting me have a suppressor here in California when I go out to the range.
That's a whole other thing.
I'm that guy on that class action lawsuit, and I'm sure I could find a shit ton of other dudes that are on it too. Like, this is my brain. This is my brain with the suppressor.
Rebecca Ivory to the witness stand. Okay, so here's what we can do to mitigate blast, and let's not have TBIs, gentlemen.
I'm all in on this. I have literally nothing better to do than to put those guys on the scene on Front Street. Okay, so let's talk about. All right, so you got all this information now. People are going, oh shit! Like, never really thought about that. I kind of have, but kind of haven't. And when she said kind of punch drunk, I've been out there for long range days when it's been all carbine for a day. And at the end of the day, I'm feeling a little maybe like more fatigued than I would typically feel. It was warm out here today, but like I've been out on the range all day before with my, with my pistol and, it's not quite the same. All right, it's a lighter weapon. Sure, it's not quite the same, but I work out, I'm physically fit. What is the shit that I'm feeling? So, again, awareness. So the next question I have for you is like you said, let the brain rest. What are the realities of that, like in terms of resting the brain and allowing it to repair? Can you give us some advice or some insight to what that looks and feels like specific to cumulative blast exposure?
Yeah. So unfortunately, it's different for everybody. How much time do you need, right? Again, I think there'll be some research coming out. I will make sure that you are aware of all of it when it comes out.
Yeah, I love that. You always send me research shit. I love it. It's great.
Totally.
I read it all.
But I would say the educated thing to say at this point is like, what symptoms are you having? And wait, if you can, wait to go back to the range until those symptoms resolve. So if you are feeling punch drunk, don't go back to the range while you're still feeling punch drunk. If you develop a headache, wait to go back to the range until your headache is resolved. That kind of thing. Just again, like that super common sense thing. And again, also understanding that like this is not possible if you have 5 days at the range and you're on a SWAT team and these are your only 5 days, 100% get it. Just saying like that's what I would recommend if the world was perfect.
So it's interesting. I did a lot of study with like concussion protocol with CC here a few years back, and there was quite a bit of research going on when the NFL was talking about CTEs
Yeah.
and things like that in a different kind of way. And there's been a lot of change, when we start looking at like how to work with the vestibular system in order for recoveries and just like eye therapies and things like that to help people recover. It used to be you get a concussion, let the brain rest, go into a dark room, sleep, and let it recover. And now it's different. Now they're like, no, that's not what you need to do. What you need to do is actually keep the brain active in a different kind of way and stimulate that vestibular system, which can stimulate the healing process. I wonder if any of that's part of this research, or is that where this is going? I mean,
you don't need to go lay down in a dark room. Honestly,
Yeah.
like sort of what I mentioned earlier, where some folks are intentionally changing their training protocols, where like you're at the range for X number of days and then you're doing like medical training for X number of days. So you're still active. You're still being stimulated. You're still going about your business. You're just not at the range.
You're not being exposed
Exactly.
to
We're not adding cumulative blast waves injuries to your brain.
Fascinating.
That's it. Yeah.
Fascinating.
Yeah.
That's super valuable. I love that. Yeah, you're my new go-to. I'm not kidding about this freaking class action lawsuit.
I love talking about this stuff. So I'll bring in like a PowerPoint presentation. It'll be awesome. Yeah. I'll have handouts for everyone. They'll be in color, lots of pink.
Love the PowerPoints. I still have your prezo. It's over here. I have your prezo from the last time I listened to you talk. It was awesome. I was only bummed that I think Jeff and Catherine kept you to like 45 minutes. I was like, no, like let her go. Like we'll push somebody else out of the itinerary here.
Nice
okay, so man, like I said at the beginning, there are so many things. I said this before we started. I'm like, God dang it! Like there's so much stuff I want to chat with you about, and there's so many different depths that we could go to, on all of these topics. And I want to reserve the right to come back and do that.
Definitely.
At some point. But I also want to know, just like kind of like you talked about all the things you've been doing, and that's a lot of stuff. Like, what does life look like for you, right now, in the future? How you're helping people, and with all the different things. I mean, I don't know how you're doing all this, but what is the reality of that? Like, how are you balancing it all, and what does it actually look like?
So I very intentionally step away from work. If I could work for 24 hours a day for months on end, and there would still be more work. So therefore, I just have to stop at a certain point. I spend most of my time during the week, my normal 8 hours of the day, doing research, working in research, working with other people who specialize in special operations, TBIs, blast, mental health. That's how I spend like the good portion of my day. And then I come home and I do all of my private practice stuff. And so it's like very frequently like a 12, 13-hour day. So I do a lot to try to take care of myself.
Mm-hmm.
And I have to say no to a lot of things. I get a lot of requests for like those mental health waiver evaluations, and those take me like 10 to 12 hours per person at least.
Wait, so talk about that, because I think we talked about that before we actually jumped on. Like, talk about that.
So I've been doing some waiver evaluations for dudes, again, in the fuller men and women context. So I do a lot of mental health evaluations for people who would like to go to selection, military special operations selection, whether it's Army. I've only done them for Army and Navy so far, but essentially people will want to join and get a special contract and go to selection, or maybe they're already in and they would like to go to selection. But at some point before then, they were diagnosed with some kind of a mental health condition, like major depressive disorder or generalized anxiety disorder. Typically when they were young, they were a child still. So they were 18 or younger.
Okay.
And now that has become a disqualifier for going even to selection, potentially depending on the branch. So I will do a forensic review of their entire medical file, and we'll also sit and talk for at least 90 minutes. And there's no guarantees, but I will take a look at their current presentation as well as all their medical records and write a letter in support as to whether they still have this condition, and it has to be a no. And frequently I'm looking to see if they were misdiagnosed or if there was anything else going on in their life where we can explain away a little bit about what happened to them.
Wow. Wow. That's very objective and subjective at the same time. So, I mean, what's the reality of that? I mean, how many of these original things are still a problem, like as a percentage, for guys that are trying to do this a little later in life?
So this is kind of an interesting thing because brain health and our understanding of the brain and mental health has changed significantly in the last 10 years.
Right.
So for example, I could get somebody who, when he was 14, his, a parent died. And as a 14-year-old back then, which could have been, 15 years ago, it was common practice to diagnose a grieving person with depression so that we could give them an SSRI. And that's not typical practice anymore because we know with grieving,
of course you're going to be depressed.
The person's going to be depressed. Of course they are. So like giving someone an SSRI isn't like our first go-to thing. So I can look at that medical record and be like, wow, first of all, never should have been given an SSRI at 14, probably, especially for this. Also, he wasn't depressed. He was grieving. This is a misdiagnosis. He does not now have major depressive disorder. I also, based on my review of all of his medical records, I don't think he ever had major depressive disorder. He should be given a waiver. So because of the changes over time, it is really interesting to look back and see what people were diagnosed with and if they even qualify for that thing currently. And that's usually the argument that I make.
It's no wonder it's a 13-hour day. I mean, there's so many things there, but the thing that I always come back to, this is what I got from you, like right away, even before we met in person, is the energy, like the passion, like the care, but also like the wanting to find out and know and learn more. It comes pouring out of you, even though you're putting in 13 hours a day and trying to get all this done. And you're so willing to give the information. And that's why it was so important for me. At one point, I was just like, gotta get her on here, because if there's any way we can get this stuff to a larger audience, like this shit needs to be talked about. And so, before we kind of get into like how people maybe get in touch with you or find out more about you, one of the questions I have is how many people are actually doing what you're doing in working in this special, I'm going to call it a special population. And what's the percentage of males to females or men to women that are actually in a position like you, helping dudes, right? Primarily that are out there struggling or wanting to get help. What can you tell me?
There are not enough of us. There are not enough of us. There are very few of us. I am pretty lonely out here. My friend and mentor, Dr. Chris Free, operator syndrome. I am lucky to be able to talk with him frequently about all of this. There are some other people and organizations who somewhat specialize with special operators. I know an art therapist. There are some other people, but not a lot. And I would actually say that it's probably a 50-50 split between men and women.
Okay.
It's pretty common for people who are women who work with special operators. A lot of them are spouses, which is great because they understand the community. They get it. Mm-hmm. And most of the men are former operators. I work with tons of physicians who are former SEALs or Green Berets or whatever. But yeah.
Wow. So it's super small. So I think there's a lot.
Tiny.
I look at that as like, wow, that's obviously I'm hopeful that changes, but with that hope, I just look at that as being a huge opportunity. Mm-hmm. And so I wonder, like, how does this then show up for people in the process of becoming, going through their degrees and the institution, that you need to go through in order to arrive at the credentials to then be in a position to do this? Like, when does it show up in the institution? And how do we get more people into this and understand that there is an opportunity here?
Yeah, so of course, like a lot of this is not taught. I actually teach nursing students. It's one of the many things I do. I teach prescribing I know.
Never
I know. Believe me, I know. I teach prescribing to psych nurse practitioner students, and I always very intentionally talk about special operators. I talk about NFL players, because I also work with NFL players. And I try to throw this stuff into the information that inside the coursework, but there is ultimately just not enough time. So if you want to get into this, I strongly urge people to actually go through school and actually get their master's degree and or their doctorate, whatever is appropriate for the thing that they need to do, and work with the general population, because this is something I did. It helped that I was a psych nurse for so long, but I actually worked in community mental health for like 7 months after I graduated. But which still was not enough time. But like, you need to know general population stuff inside and out to work with this community in your specialty area, because you have to be able to know that this is different.
And contrast. Yeah, compare and contrast.
Yeah,
so important. Yeah, I love that. You got to do the work. I mean,
you do. There's nothing will ever replace actually going through and getting your degree and doing all the qualifying things to do this. I don't mean to be like a gatekeeper, but like you have the potential to really mess people up.
So we talked about this before we started, and I often have folks that work in mental health and emotional health world kind of reach out because they've heard other podcasts with me, with people like you, and they're like, hey, they would, like I work with similar groups of people and so forth, and like me on the show, and I have come across some things that really concern me. It's much like what I see. I mentioned this is an opportunity. Right. And when there's an opportunity, there's potential money to be made or attention to grab, if you will. And I'm very cautious of that. Again, for people that know the show, like I'm from the fitness industry. Nobody does it better, attention grabbing worse or better, however you want to weigh that, than that industry, with the exception of the firearms industry, which is equally as ridiculous sometimes. And so I think it's a very good point that you just brought up there, in that you have to be cautious, and that the risks involved with not knowing what you don't know could be detrimental, right? And I think that goes for any profession, but particularly obviously for this one. And so using caution in who you're listening to, who you're getting your information from, but also respecting that somebody that may not quite be there yet, that is on their journey, is, again, remember, they're on their journey, and they may have to find, things out along, just like you did along the way, like, holy shit, this is not what I thought it was at times. And we have to maybe course correct or make some adjustments. Not, not that you were doing something wrong, but you didn't know what you didn't know. Right. And it took a lot of work to get to where you're at. I respect the hell out of that. So, all right. So in wrapping this up, because like I said, I could go on for hours talking to you about all the things. How do people find out more about you? Where do they go to find out about tactical psychiatry, the work that you're doing, the research that you're doing, all of that stuff?
The very best place that anyone can find me is on Instagram as Tactical Psychiatry. That is my name on Instagram. I do have a website, tacticalpsychiatry.com. It's sort of a static website, because really I am very busy. If you want to contact me, I'm Rebeca at tacticalpsychiatry.com. I recommend email and I recommend Instagram. And those are the two very best ways to get in touch.
I don't know how you're keeping it up with it all. I don't know. You need an assistant or an AI assistant or something.
I do.
If you don't already have that, I mean, you put out the job description now and get you hooked up. It's amazing. Look, again, this has been about an hour and 25 minutes of just so many things. If you hung in there this long in the podcast, it's because you recognize there are so many things to know and to listen to, and the stuff that you're doing, Rebeca, is I think is it's important shit. And it's also fascinating to me because I do understand human physiology and to a certain extent, and I've worked with and around folks, and then also obviously had them on the show that have gone through their own experiences. And I mean, you hit so many points that have come up in their journeys that they've shared in so many ways. So I know this isn't like, people could be looking at this like, well, she she didn't really tell us exactly how to do it. This is kind of woo-woo. Like, well, you can think that if you want. Like, go right ahead. That's very reductive, and you can boil it down to that if you'd like. And I don't think you did that at all. I think you did a fucking amazing job at putting all that information out there and putting up with me with all my questions, and
it's been
really not being able to talk at a deep level like you probably talk to with your colleagues. So the fact that you only have a few hours in every day to maybe take care of yourself or talk to friends or downregulate or sign off or do the things that you
Sleep.
do. The fact that you spent that time with me, I cannot tell you how appreciative I am. Thank you so much.
Thank you for having me. This has been awesome. Thank you so much.
Yeah. Again, there's got to be a next time. We have to put that next time together. Definitely. All right. Thanks, Rebecca. Appreciate you.
Yeah. Thank you.